So let's tackle a really fascinating question today. How do doctors examine the one part of us they can't physically see or touch? The mind. We're going to break down the methodical process of a psychiatric evaluation, which is, you'll see, a really structured journey into our own thoughts and feelings.
I mean, it's a fundamental question, right? In pretty much every other part of medicine, doctors have all these amazing instruments that can see and measure and test what our bodies are doing. But what happens when the thing you're trying to examine is the mind itself? The toolkit has to be completely different.
And this slide right here really gets to the heart of it. A physical exam, it uses tools like stethoscopes and x-rays to find objective signs, things you can measure. The psychiatric exam, though, uses a structured conversation as its main instrument to basically map out a patient's inner world. The real goal is to translate all of that subjective experience into a clear, objective assessment.
All right, so here's our roadmap for this explainer. First, we'll get into the art of the interview itself. Then, we'll see how clinicians build out the patient's complete story. After that, we're going to spend a good bit of time on the mental status exam, and you should really think of this as the physical exam for the mind. Then, we'll look at how physical health plays a role, and finally, how all these pieces come together to form a real plan.
First up, the art of the interview. And this is so important. This is not just some casual chat. Every single part of it, from the specific questions they ask to the way the room is set up, is carefully designed to make this a powerful diagnostic tool. It's all about turning open communication into crucial clinical data.
And it all starts with the setting. The space has to be quiet, it has to be private, and it has to feel genuinely safe. This is absolutely essential for building the kind of trust that allows a patient to really open up. So a clinician will introduce themselves, they'll explain why they're meeting, and then they'll start with these broad, open-ended questions, basically inviting the patient to tell their story in their own words.
Now, a really powerful strategy that clinicians often use is called R's. It comes from an approach called motivational interviewing, and it's an acronym for open-ended questions, affirmations to build up their confidence, reflective listening to show you're actually hearing them, and then summaries to make sure everyone's on the same page. This framework is just incredibly useful for navigating really sensitive topics, like substance use, with a ton of empathy and support.
So, once that initial trust starts to build, the next step is putting together the full story. Because here's the thing, a good evaluation is not just a snapshot in time. It's really about constructing a detailed history to understand the complete context of the patient's life and their challenges.
So how do they build that story? Well, they tend to focus on three key histories. First, you've got the psychiatric history, which covers past diagnoses, and this is huge, what treatments have worked or, just as importantly, haven't worked. Second is the social history. This gives vital context, things like stress at work or how strong their support system is. And finally, the medication history. This is absolutely critical because some medical drugs can actually cause psychiatric symptoms, and you've got to know if a patient is taking their medication like they're supposed to.
Okay, now we get to the real centerpiece of the whole evaluation, the mental status examination, or the MSC. If the interview is the art of conversation, then the MSC is the science of systematic observation. It is truly the physical exam of psychiatry.
So what's the whole point of the MSE? It's really all about methodically documenting a patient's mental state in that specific moment. Just think of it like a structured framework for observing and recording everything from their appearance to their thought processes and creating an objective snapshot from all that subjective information they've been gathering.
And what's really interesting here is just how comprehensive the MSE is. It breaks down the assessment into all these different domains you see on the slide. This isn't just about what the patient says. It's around observing their grooming, their motor activity, their speech patterns, their emotional state. All these little things are clues. Let's zoom in on a few of the most important ones.
Okay, this is one of the first and maybe most important distinctions a clinician has to make, the difference between affect and mood. It's simple, but it's vital. Mood is what the patient reports feeling, like, I feel sad. Affect is the emotional tone the clinician observes, the flat expression, the tearfulness, the agitated way they're talking. A mismatch between the two, say someone telling you they're happy while they look absolutely miserable, that can be a really significant clinical clue.
This slide is great because it really shows how speech can be a direct window into someone's thought process. Clinicians listen not just to what a patient says, but how they say it. Is their speech pressured, like they just can't get the words out fast enough? Are they jumping from one idea to a totally unrelated one? That's called flight of ideas. Or maybe they suddenly stop mid-sentence, a thing called thought blocking. Each one of these is an objective clue to what's going on inside.
Now, when it comes to assessing thought content, a huge area of focus is looking for delusions. A delusion is a fixed, false belief that a person holds on to no matter what, even when you show them clear evidence that it's not true. And the cultural context part here is vital. A belief isn't considered delusional if it's a widely accepted part of that person's culture or religion. That's a super critical distinction to make.
Next up, we've got hallucinations. So a hallucination is a false sensory perception. And the key phrase to remember here is without an external stimulus. The person is genuinely hearing or seeing or feeling something that just isn't there. And this can happen with any of the five senses, from hearing voices to feeling things on your skin.
And that brings us to illusions, which people often confuse with hallucinations, but they're very different. An illusion is a misinterpretation of a real stimulus. There is something actually there, like that coat rack in a dark room, but the brain messes up and interprets it as something else, like a person. So with an illusion, the stimulus is real, but the perception is wrong.
But look, a complete evaluation can't just stop with the mind. A core principle of psychiatry is to always rule out underlying medical conditions first. So many physical illnesses can cause or mimic psychiatric symptoms because, the mind doesn't exist in a vacuum. It's deeply connected to the rest of the body. And this is exactly why a physical exam and lab work are so essential. A urine tox screen can tell you if substances are a factor. Endocrine tests might reveal that a thyroid problem is actually what's causing someone's anxiety. A brain scan could find structural issues, while simple blood tests might uncover vitamin deficiencies that are known to cause big changes in mood or thinking.
So after gathering all of this information, from the interview, the histories, the MSE, the physical tests, the clinician's job is to put all those pieces of the puzzle together. This is the final path, moving from all that data collection to a diagnosis and then finally to a real treatment plan. And there's one more tool that really helps in this final phase: psychiatric rating scales. These are basically questionnaires that help quantify subjective symptoms. For example, by asking a patient to rate their anxiety on a scale of 1 to 10, a clinician can get a baseline. This lets them objectively track how the patient is responding to treatment over time, adding another really important layer of data to the whole process.
And in the end, this all fits into this dynamic, ongoing cycle of care. A clinician collects the data, they assess it to form a diagnosis, they develop a plan with the patient, they implement that plan, and then, and this is so important, they follow up to monitor progress and adjust things as needed. It just goes to show that an evaluation isn't a one-time thing. It's a continuous, collaborative process.
So when you see it all laid out like this, it's pretty clear that the psychiatric evaluation is this intricate blend of the art of human connection and the science of systematic observation. It's so much more than just a chat. It's a deep, methodical, and compassionate process. So with that in mind, I'll just leave you with this question. How does understanding this structure change the way you think about a mental health diagnosis?